Please. So thank you for having us here as a moderator. Next session will be virtual. Dr. Zenida Pirik. She's head the Department of Hematology Internal Medicine Clinic, University Hospital Center, Croatia. She's assistant professor, Department of Medicine, University of Rijeka Medical School, chair, Transplant Complication Working Party, European Society for Blood and Marrow Transplantation. She's also a co-leader in Acute Lymphoblastic Leukemia Subcommittee, Acute Leukemia Working Party, and EBMT. She is also assistant professor at Department of Medicine, University of Zagreb Medical School. So welcome, Dr. Zenida.
Hello, can you hear me? I'm not sure if you can hear me.
Yes, we can hear you.
Okay. Thank you so much. Good day to everyone, and thanks for the kind introduction. So basically, I've been interested in GVHD for a long time, and currently I lead the GVHD subcommittee. And some of the talk that I'm going to give today is a result of, let's say, some recent improvements in GVHD and directions that we are trying to take in the EBMT as well. It is really my great pleasure to be here, and thank you so much for the kind invitation. I will try to recreate the talk I gave at EBMT. And this was actually a session on, let's say, something more in intestinal GVHD than just giving the drugs, so supportive care, and how supportive care can improve intestinal GVHD. And my talk is focused basically on nutrition and supplementation. So this is the outline of my talk. I will start with what we currently know on nutritional support in GVHD, and then let's say a little bit dissect routes of nutritional support, diet intervention, and supplementation in intestinal GVHD, in order to try to, let's say, give some kind of framework for some future directions, as I already said, that we are trying to take in EBMT and in the GVHD subcommittee of the Complications Working Party. Basically, when we talk about guidelines and recommendations in intestinal GVHD, well, basically on nutrition guidelines in general in stem cell transplantation, the data is really scarce. There were two efforts in the last, well, almost 10 years in EBMT. The first one was in 2018, when in the Transplant Complications Working Party, we tried to conduct a survey and assess nutritional practices in stem cell transplant centers along Europe. And we actually saw back then that only half of the centers in Europe actually, or EBMT centers in general, have standard operating procedures when it comes to nutrition and intestinal GVHD. And also that there is a great variability of practices when it comes to intestinal GVHD, even when when it comes to stopping and introducing oral intake. And you can see here that there's approximately a fourth of centers doing their own way. So some of them never stop intestinal oral intake, and some of them stop it when there is a huge amount of diarrhea, more than 1.5 liters, while others have a slightly different practice. And also at that time, the use of parenteral nutrition was, let's say, still very popular and very used, especially in these patients who have no oral intake. And what was also evident back then, that there was a great variability on how and when introduce parenteral nutrition. The next, let's say, effort was made a bit more recently, and that was in 2023, again by the EBMT, but this time the Cellular Therapy Working Party and Nurses Group Working Party. But although they did, let's say, a huge effort, they could not give some straightforward guidelines. Just some, let's say, updates on the knowledge that we have gained over the last decade or even a bit more, and that is that neutropenic diet does not reduce the infection date. There is no evidence to support the neutropenic diet, so this is not supported by EBMT anymore either. And also with gaining knowledge on enteral versus parenteral nutrition, and this is, let's say, the same as it is in European nutrition guidelines of nutritional societies, that enteral nutrition should be preferred in comparison to parenteral nutrition, as it is more physiological. Also, some of the additions that we used to add to parenteral nutrition, as glutamine, is not anymore recommended due to the lack of data. And also, although we are talking a lot about probiotics, there is still nothing that we can say has been proven and that we can, let's say, safely and with some result use it in transplant recipients. In intestinal GVHD, we know that, well, for decades, this was the standard, the stepwise upgrade diet, where we usually would stop feeding patients in grade 3 and 4 acute GVHD. And I know that everybody who has been doing transplant for some year has this, let's say, recollections of these patients who have not been eating for weeks. And to me, it was always so unphysiological, I would say, because these patients really deteriorate little by little. Then usually when the grade 4 to 3 becomes 3 to 2 acute GVHD, a clear liquid diet was started. And then with improvement further of GVHD, the diet would be introduced, but that would be a low lactose, low fat, low fiber, and low acid diet. And then the ingredients would be, let's say, added one by one and very slowly. So this going back to normal eating I would say, last 4 months. I will now try to dissect all of these parts of what I've said so far, so what we knew or what we know so far on nutrition. And I've tried to focus only, let's say, on clinical data and data in transplant recipients. But first of all, I have to say that our perception has changed a lot. When it comes to pathophysiology of intestinal GVHD, now we know it's not only about T cells and T cell response. We know that GVHD, well, that actually healthy gut barrier and healthy microbiota are protective factors against GVHD, and healthy nutritional status is protective of healthy gut barrier and normal microbiota. And this is true for oral intake, and if not oral, then enteral intake instead of parenteral, so feeding the let's say the good microbiota. We have learned a lot about the disruption of gut barrier and dysbiosis. We know that the good bacteria are the anaerobes, which get lost with the use of conditioning regimen, with antibiotics, and then further with GVHD. We know that there are some bacteria that have, let's say, properties as probiotics to, let's say, prevent or protect from GVHD, as lactobacillus. And we also know that Enterococcus is the one bacteria that has been recognized as very important as a bad one, let's say, recognized in the pathogenesis of GVHD. So knowing all that, of course, it becomes attractive to find ways to strengthen the gut barrier and maintain oral nutrition before transplant. And then, of course, when it's needed to initiate enteral nutrition instead of parenteral, in order to prevent, reduce, and let's say treat GVHD. Let's go back to the nihil peros strategy. There are data today, and these are even some, let's say, older data here shown on the left, where a study in more than 200 transplant patients has shown that actually the incidence of QGVHD, of grade 3 to 4 GVHD, is related to the days with no oral intake, and you can see how the incidence increases with a higher number of patients who are not eating. And actually, in the multivariate analysis, the more than 9 days with no oral intake was associated with grade 3 to 4 acute GVHD grades. And then furthermore, and that is shown here on the right, and that is an analysis of patients who have been transplanted in the hospitals and as outpatients, around 80 of them, where actually you could see that acute GVHD grades 2 to 4 were associated with hospital care. Patients who were in the hospital had less oral intake, and this was then further associated. So poor oral nutrition was again associated with higher grades acute GVHD. Then when it comes to parenteral versus enteral nutrition, there were some efforts, prospective efforts, but then not all studies, let's say, were conducted until the end, but still studies that we have altogether enabled us to have a good meta-analysis, and this is the one shown here on the left. A more recent one, where it has become clear and, let's say, adopted that enteral nutrition during the neutropenic period is associated with reduced incidences of grade 3 to 4 acute GVHD, and in particular intestinal GVHD. And then here on the right, and that is a pediatric study where two groups of 20 patients, in each were fed enterally and parenterally, and their microbiome diversity was analyzed. And you can see, because enteral is here in this chart on the left, and the red ones are the parenteral nutrition, you can see with enteral introduction how microbial diversity recovers, while it parenteral even decreases further down. And on the right side, you can see again in blue enteral and in red parenteral nutrition, and the levels of short chain fatty acids, which are improved with enteral nutrition. And we know that these short chain fatty acids, as the products of good bacteria, are actually important for restoration of gut barrier. Then there is another interesting thing. I have mentioned Enterococcus, and I would say that the hugest data set that we have when it comes to nutrition and microbiota comes from the group of the Sloan Kettering, and this is what is shown here on the left. This is more than 1,300 patients treated with allotransplant. where the microbiota diversity was checked, and what they saw is that this high incidence of enterococcal expansion is associated with grade 2 to 4 QGVHD and significantly heightens the GVHD-related mortality. And then further, and that's clinical data, but then further, this was extrapolated to mice. And actually, when you stop lactosis in mice, you can attenuate enterococcus outgrowth. And there are also some smaller clinical data confirming that. And that is what I've shown here on the right. This is clinical data on a lactose-free diet in BMT recipients when around 30 patients got a lactose and the other ones got the lactose-free diet during the before and during the allogeneic transplant. And you could see here that actually this lactose-free group had a significantly less colonization with the worst enterococcus, and that is the vancomycin-resistant enterococcus, which of course we know always we have lots of multi-drug resistant bacteria. We always fear from the gram-negative ones because of course they're the deadly ones, but the vancomycin-resistant enterococcus is a real problem when it comes to GVHD. As I said again, the hugest data set is from Sloan Kettering, and this is a study that is really nice where they very detailed checked the diet of patients during stem cell transplantation, so almost 160 patients, and they checked their meals in very many details, so they had to write down everything they ate, and then they serially checked their fecal samples for microbiota diversity as well. And then you can see on the left side how the caloric intake decreases with the duration of the allogeneic transplantation, and as well as the diet diversity decreases, as well as microbiome diversity. So how the transplant is, let's say, taking place, and then further in the post-transplant period. And then what is, I would say, the most interesting here, and this is what you can see on the right, is that intake of among all the food that has been analyzed, intake of sweets or sugars is associated with enterococcus expansion. And also Blautia, abundance Blautia is one of the bacteria that has been recognized as a good bacteria and protective from GVHD when it comes to the microbiome. But when you say sugars and sweet, well, at least I think of chocolate or something like that at first, but it's not quite like that. So first of all, what is important is this intake of sweets or sugar was associated with enterococcus expansion, but during the antibiotic exposure. So actually you deprive the good microbiota with antibiotics, and then you feed the bad one with sugar. So it makes sense. But then in the middle here in the pink part, you can see what I found the most interesting, and that is the fact that these sugars that we are talking about are not chocolates and sweet, but actually enteral formula. So the drinks like Ensure, Prosure, something like that, something that we usually are pushing into our patients who are not eating. And this also was confirmed in mice. So sucrose exacerbated the antibiotic-induced enterococcus expansion in mice. I will move on to fiber. As I said, first the enteral nutrition. When we start the liquid enteral nutrition, this is the one that actually does not have fiber. And in the stepwise diet, I have shown that we introduce fiber usually very gradually. This is a very, very nice study that actually evaluated food intervention outcomes on the microbiome in human, and there were three different diets that were tried. So the omnivore, so eating, let's say, everything, the vegan, and then exclusive enteral nutrition, which is fiber free. So the enteral nutrition that we are promoting as well. And what they found in these patients, well, actually the healthy volunteers, is that they also did this intervention with antibiotics. So they did the depletion of gut microbiota with antibiotics. So in the middle here you can see how omnivore and vegan, but not exclusive enteral nutrition, supported the growth of the good bacteria, which also correlated with, so the enteral nutrition correlated with abundance of short-chain fatty acids, so the good short-chain fatty acids. So this brought them to the conclusion that actually fiber, which was not in the enteral nutrition, but was in the other two diets, has an important role in preservation of microbiome mass and diversity, and also after the depletion with antibiotics, with the recovery of the gut microbiome. So fiber is very important, and prebiotics as fibers have been evaluated in the transplant setting. They have been shown to stabilize the microbiome and mitigate the GVHD-induced damage of target organs, which you can see here on the left. And prebiotic mixtures, resistant starch, were used in humans while undergoing, of course, transplant, and decreased the severity of both mucositis and grade 2 to 4 GVHD. But today, we still do not have a very clear knowledge what is the best and what we could use, or something that was evaluated in a way that we can, let's say, accept it. But data are emerging. This is also very interesting, what I'm showing here on the right, and this is a small, again, data set of 10 patients who had a standard enteral nutrition, and then 20 patients who had enteral nutrition but with fiber, so with added fiber. And actually, this study has shown that adding prebiotic fiber to enteral nutrition is tolerable, first of all. And what was also very nicely shown, that these addition can actually benefit the abundance of lactobacillus, so let's say improve the number of lactobacillus, which was shown as, let's say, a protective bacteria when it comes to GVHD. Of course, when it comes to probiotics, we today know a lot about, let's say, the ultimate probiotic, and that is, of course, fecal microbiota transplantation, which has been today used in the treatment of GVHD. There are studies using it as a preventive strategy as well, and this is something that will become, let's say, clear in the future, but it's something that really helps when immunosuppression is not working. So to restore the gut barrier, this is something what the FMT does, the good bacteria which come from FFT. But of course, FMT has some problems, are, let's say, problems of choice of donor, and then problems of engraftment, because not all FMTs engraft, making us actually speculate that there is something else that we need to do in order to help this microbiota engraft. And this is a slide that I've shared from my colleague, Dr. Jaime Sanz from Valencia, who has been doing FMT in GVHD patients, and then added on nutritional interventions, I would say, that might help engraftment. This is, I think, a very good model of how GVHD diet today should look like more. So try to avoid complete cessation of oral intake, even in the severe diarrhea period, in order to support the mucosal integrity and giving food to microbiota as well. Of course, avoiding unnecessary antibiotics and excess simple sugars, and try to start with low residual, low lactose-free and low-fat diet as soon as possible. And then as soon as diarrhea improves a bit, gradually introduce soluble fiber in order to support production of short-chain fatty acids and to help this epithelial healing and microbiota recovery. And then gradually increase dietary fiber and diversity in order to